we doctors are told from medical care, and one of the debaters mentioned it, that something like 60% of illnesses are self-limiting and don't need any care. This is true. And this also means that we need a lot of primary care and some secondary care and very little tertiary. So perhaps not the goal of everybody should be to be delivering tertiary care. This is what I'm suggesting to you. I was saying it in a subtle way, now I'm telling it to you direct. So the goal of a successful doctor need not necessarily be the one who is delivering high technology care in a corporate hospital. We have to remember, many of the debaters said it, you know, that you need empathy, you need to be a counselor, but I can tell you that nearly every one of them is going to forget it when they finish the medical college. They are also going to aspire to a postgraduate seat. I did the same. I walked through the same path. I wondered whether I wanted to sit in a primary health center and treat all at primary care, and it didn't appeal to me. So, but you can find that in developed countries, in the UK, it's very common. General practitioners, people love doing general practice. So it's a change in the way we think. So we have to think of all these things in advance. What do we do? How will we plan your career? It is in India because money is more, social prestige is more, all of us want to be specialists. But think about it, is that what I really want to do in life? Am I really happy doing this? Because a lot of burnout happens because people who don't really want to do this, they do it out of following the herd. Let me give you some ideas about the public sector where you can handle the ideas of integrity. The question is, am I doing enough? So I would guess that if a person has 2-day fever, if you do a perfunctory examination, which is all that's possible, and are sure that he's not having some serious illness like dengue, and you ask him to come back if the fever doesn't go, it's good enough. So you finish fast. So you are doing a quick triage. This is not the best way to do things, but in good societies, you will have a structured medical care where this is not required. But this is how one has to handle it in India. Are you spending enough time? Are you listening to the history long enough to be able to make the correct diagnosis, or are you skipping the history and jumping from history, no clinical examination? Are you spending enough time? This is the question. Enough time doesn't necessarily mean 30 minutes for every patient. It may not be possible, but enough to have a fair idea of what is going on there. And is the patient getting the best care available? If certain infrastructure is not available in your hospital, that is something that maybe if you are a very public-spirited citizen, you should also campaign in the society for it. But that is not an essential part. But it is definitely required that you give the best available care. And that doesn't mean necessarily only the best available care in your hospital. It could be the best available care that the patient is able to afford. If you do not have a test in your college, when I was coming in, I saw you have CT and MRI here. But if you don't, and you need to send the patient to the Rajiv Gandhi Government Medical College to get that test done, maybe that's a good thing to do. So you should, what is available for the patient? We have to remember that David Sackett, the godfather of evidence-based medicine, he clearly defined evidence-based medicine. He said, give the best available care, taking into consideration the social situation in which you work. It does not mean giving the so-called ideal care. When you go for medical conferences, you will often hear the question, what's the ideal treatment? The ideal treatment is not an abstract concept which hangs around in the air. The ideal treatment is taking into consideration, which shows formally to all of us, the social determinant of disease. Can the patient afford it? Are you going to bankrupt the patient, giving him a treatment which he can't afford? You have to keep that in mind. So you advise them, you tell them, and take the patient on board. That's autonomy. You have to be an advocate for patients. You can't say that this is not available in my hospital and that's the end of it. If you need, if you're working in a government hospital, say for example, I give you an example from my own subject, orthopedics. Open fractures, the bone needs to be covered. Plastic surgeons, there are very few in India. You need to learn to do the flap. So there are many places in India where the orthopedic surgeons, they train themselves to do the flap, so that you can cover the bone. Otherwise, the patient, that bone is dead and the patient's leg is gone. So push the barrier. Try to add skills to yourself which will help the patient. It will give you a lot of satisfaction, but it will definitely help the patient. Now, I can give you a few scenarios. Suppose you are in a public sector hospital, okay, and a patient comes who needs dialysis. I'm very sure, it was definitely the case when I was a medical student, and I guess it's the case now also, because chronic renal failure in India is very, very common because of the epidemic of diabetes. When I was younger, there wasn't such an epidemic of diabetes, but there was still renal failure, and that was due to very often due to taking toxic substances in work. But nowadays, it's mainly due to diabetes. Suppose you are in charge of a dialysis unit, and you have many more patients than you can actually dialyze. What is the ethical thing to do? In the best possible society, you won't have to make this decision. It will already be decided that you do dialysis for these patients and you don't do dialysis, or you do a few for them and all of that. But here you have no option but to decide on the resource allocation yourself. So keep in mind integrity, and then you cannot run away from this, and you can't say that every patient who comes on that day I will dialyze him and send him away. First come, first serve. That's not a real answer. So you have to think about, how will I allocate the resources which are given to me? Suppose you are a general surgeon, and you know now that the gold standard treatment of when you do a cholecystectomy is laparoscopic cholecystectomy. And you are in a remote place, say somewhere in Bihar, where you have no access to this laparoscopic instruments, but you know how to do an open cholecystectomy. Will you do it? Or will you be afraid that if I go to the conference, all my colleagues are going to ridicule me saying, hey, you're backward, you never progressed. We are all doing laparoscopic cholecystectomy. Why are you still doing open? Are you going to be afraid of that? Or are you going to do what the patient needs? Patient has no option to go to a place where a laparoscopic cholecystectomy is available. Are you going to feel like a lesser human being because you're doing the open procedure and not the laparoscopic, the latest expensive procedure? You need to think about all these things, and that's why reading helps, because a lot of these questions have been debated. Maybe you don't have final answers, because society keeps changing and the answers have to keep changing as the society changes. But it will give you great belief. You need self-esteem to have integrity, and it will give you self-esteem in deciding what you're going to do. You take another case scenario from the public sector, one from my own field. If you have a fractured both bones of your leg, that is the tibia and the fibula, the current procedure anywhere, and definitely in Isabel hospital, if the patient can afford it, even I will do it, is to put an interlocking nail. But to put in the interlocking nail, you need a lot of expensive infrastructure. If you are in a remote place, or the patient can't afford this interlocking nail, would you do what Samiento clearly showed works very well and gives equally good results in the long term? That is a functional cast brace. Samiento became the president of the American Orthopaedic Association. For a long time, he spent his life working in Los Angeles, and he worked in a public hospital where a number of drug addicts were treated. And there the compliance rate is very low, and though they had infrastructure, they would not do this nail because infection rate was very high among these people. And if you use a functional cast brace, infection rate is 0 because there is no surgery. So he has published any number of papers showing that the long-term results of a functional cast brace equal those of the interlocking nail. So would you do that? Or would you say, everybody's going to make fun of me, if I can't do the interlocking nail, I'm not going to do anything? So these are questions that you will be faced every day if you work in the public sector. On the private sector, the questions are different. It's all about financial reward. It's very, very, very important. You know, in many private sector hospitals, maybe you've heard, people are paid consultants are paid very large quantities of money. Now the person who's running it is a businessman. He's not paying you that amount of money just so that you don't make any money for him. If he is paying you 5 lakhs a month, you definitely have to earn more than that. And therefore, the pressure is on you always when the patient comes in. Are you going to do what is the best practice for the patient, or are you going to do what is financially the most rewarding for you? This is a question. You better be aware of all these things before you enter. Don't be fooled by those beautiful looking pictures, and don't be fooled by those glamorous cars, the BMW and the Mercedes-Benz that the doctor is riding. I'm sure that many of them, in fact, I'm very sure because many of them have personally told me, lots of things go on in their head. So think about it. In the private sector, you're going to face these questions of your integrity. Are you going to do what is financially most rewarding for you? Or are you going to do what is best practice for the patient? Very soon, you know, human beings are masters of self-deception. They adapt. That's what helps us to live. Very soon you'll be saying to yourself that, yeah, that's actually the right thing to do. I read this paper. You know, one of the debaters said that so many papers come in and the artificial intelligence store all those papers. But we know that not every paper has good evidence in it. In fact, John Ioannidis, one of the pioneers, again a very strong proponent of evidence-based medicine, he said that 85% of the papers are junk, absolute junk. Unfortunately, you know, you have pressures, like the Medical Council of India says that if you want to become a professor, you need to write 2 papers. So you write 2 papers, whether it carries any meaning or not. And this has been there in the West for a long time. So you have a paper industry. You keep on writing papers, not because they're adding information or knowledge to the society, but simply because that's what you have to do. Otherwise you're not going to get, I mean, somebody tells me that, you know, you're going to remain an assistant professor, not become an associate, unless you produce 2 papers. It's a problem. I'm going to produce 2 papers. Whether those papers are going to be of any value, anybody ever going to read them, doesn't matter. I produce 2 papers, MCI came, it's in the PubMed, it's in Medline, and I'm through. And after that I wait for another 2 years, and I need another 2 papers, yes, produce those 2 papers. So this is happening all over the world. The amount of actual information that is useful to the medical practice, that takes a long time to come. So we have to remember that not everything which comes in a paper, and you don't fool yourself, that, you know, somebody said it in some conference, this is the latest thing to do. Do what is in the interest of the patient, not what is in your interest. That's the first principle. Keep the patient's interest foremost, and that includes his financial interest. And you know, cut practice. It was very, very famous in Mumbai. And actually, it's specifically forbidden in the Medical Council of India Code of Ethics. That is, you send a patient to a specialist, and they give you, they send you a check for having sent the patient. It's happening all the time in India. Every cardiologist will tell you, in Chennai too, every cardiologist will tell you that you send a patient for a coronary angiogram to XYZ hospital. As soon as the patient reaches there, you will get the check. That's specifically forbidden. And that is definitely wrong, because it gives you an incentive to do more than is actually needed. So that's what cut practice is. Now there are many forms of this. Sometimes, you know, people are so desperate, they're not making enough money. So what they do is they decide on a group practice. 4 of us get together. One is an orthopedic surgeon, one is a general surgeon, one is a physician, and one is something else. And you say, every patient who comes to me, I send it to you. So you send the patient on a carousel. Okay, every patient who comes to the ortho surgeon needs also an abdominal examination. That's a form of cut practice. It's very easy to fall into all this when you have immense financial pressures and you need to earn money. So, be aware that all those glamorous pictures, they hide certain realities. So I'm giving you a case scenario from private practice, which I really actually heard about. Now the hospital in which you work has bought a new 3 Tesla MRI machine. And you know that for your practice, you don't need 3 Tesla. 1.5 is more than enough. In orthopedics, by and large, it's more than enough. We don't need 3 Tesla. And generally speaking, now in Chennai, the charge for a 1.5 Tesla machine for doing a spine examination is about 3,000 rupees. That's about the right rate to pay. Even in the government Rajiv Gandhi Hospital, they collect around about that. But the 3 Tesla machine is a more powerful machine, and definitely it's going to cost, even without any kickback, it's going to cost you 4 or 5. So the hospital in which you work has got now this 3 Tesla machine, and they're not getting enough patients. So they tell you, hey, stop this business and you please send them all to the 3 Tesla machine. So do you fall in line or do you not fall in line? No. I hope I'll be alive another 15 years down. I will take your number and I will remember you, and I will hope that you will hold on to that 15 years down the line. I'll be out of medical practice at that time, but I would really like to see what you do. Okay, because this is a pressure that private people in corporate hospitals face every day. And unfortunately, most of them succumb. They tell you they're sad about it, but they succumb. The group referral I already spoke about. And then, whether you're in public sector or in private sector, remember, no single one of us is divine. Somebody also said, one of the debaters said, to err is human. Exactly, to err is human. In your medical practice, there is going to be some time in your life when, in spite of the best effort, you're going to make a mistake. I can say it's happened to me, and it is one of the most devastating experiences that a doctor can have. To have a mishap, it's devastating. And at that point of time, how you react, how do you act, how do you tell this patient, how do you communicate? It is the worst test of your integrity that one can ever go through. It is the most difficult test of integrity. Therefore, I suggest to you that in this position, when you are there, every college and every hospital actually should have a clinical ethics unit. They should have support for the doctor to be able to convey such kind of bad news to the patient without taking all the guilt on themselves. You know, there is an idea in the US. In the US, in medical practice, many are bad ideas, but they have a very good idea called no-fault compensation, where if there is a medical mishap, compensation is given to the hospital from a fund with no fault. There's no fault. It's not that the doctor has committed a fault. It's not a fault. Error to err is human. Everybody knows it. You're going to make a mistake sometime, however careful you are. And if you have this background, that you have a clinical ethics unit, you have a support group with whom you can take help, that would be, I was told by a doctor in Pakistan that they do have it in Pakistan in many hospitals. I would strongly suggest that you try to build this in every hospital that you work, a clinical ethics unit, so that the mishap can be told to the patient, because our ethical duty, we have to communicate to the patient. At the same time, it's going to make a lot of difference to the doctor. So dealing with it needs support. Also be aware that if during your long career in medicine, you have difficulty, there is no shame in going for counseling. You have to remember that is also a science and an art. So be ready to take support. It is essential to maintain yourself as an integral human being. Unless you're an integral human being, you cannot deliver medical care with integrity. So one of the first steps would be to decide on a career plan. Don't wait, like till the last minute.